Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Saag, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. Welcome to the Going Antiviral podcast. Today, October 29, 2024, we are speaking with Dr. Jason Zucker, Assistant Professor of Medicine at Columbia University and Assistant Medical Director of the New York City STD Prevention Training Center. Dr. Zucker is an experienced HIV treatment and prevention physician and provides status-neutral care to patients of all ages in New York. Given his focus on sexual health in New York City, Dr. Zucker has been actively involved in the recent 2022 Mpox outbreak. He is vice chair of the NIH-funded study of Tecovirimat for Human Mpox Virus, or otherwise known as the STOMP study. Today, Dr. Zucker joins us to provide an update on Mpox, a public health emergency. Jason, welcome to the podcast.
Thank you for having me.
It's great to have you, and we got a lot to cover, so we'll jump right into it. Let's start with basics. What is Mpox?
Yeah, so Mpox is a disease caused by the monkeypox virus. It's a zoonotic orthopox virus that's actually closely related to smallpox.
And does it originated in Africa, right? Originally, as far as we know.
That's right. There are two different clades or strains of the monkeypox virus. Clade 1, which we historically think of as being found in Central Africa, and clade 2, which is predominantly responsible for outbreaks in Western Africa, and was the strain responsible for the outbreak that we saw from 2022 moving forward worldwide.
So there's a new outbreak right now, right? And that's more the clade 1 variety, is that correct?
That's correct. The ongoing outbreak in the Democratic Republic of the Congo is the clade 1 monkeypox virus. We're also seeing a division in that. We're seeing sort of clade 1A, which is the traditional one, and clade 1B, which is associated with more person-to-person or human-to-human transmission.
And there's a difference between clade 1 and clade 2 in terms of vaccine coverage. Is that right? Or they're equally protected by the current vaccines?
Yeah, they should be equally covered by the current vaccines. There's not thought to be a difference in vaccine coverage between them. They should both be well covered with the current Mpox vaccines that are available. The challenge is getting them into places where they need them.
Okay. So getting, again, back to basics, in general, how is Mpox transmitted?
So Mpox is transmitted primarily through prolonged direct contact between people, either with infectious lesions, body fluids, or contaminated materials like soft porous materials like linens or bed sheets. This includes close physical contact like skin-to-skin contact, which often happens during sexual activity, which really seemed to be the big driver during the 2022 outbreak. I'll also mention that that's what we saw during the large outbreak. We know that in some of the African outbreaks, zoonotic spread or spread from animals to humans has really been a significant driver, particularly of clade 1A transmission.
And do the patients, like in the original outbreak in 2022 in the U.S., did the patients have to have open lesions for transmission to happen, or could it be transmitted more through, I guess, more silent approaches where it might be rectal lesions that might not be seen, or perhaps oral lesions?
That's a great question. And I think we know now what we've learned during the 2022 outbreak is that you can definitely see asymptomatic spread or pre-symptomatic spread. Through contact investigations, they were actually able to identify between couples examples of both pre-symptomatic and asymptomatic spread of virus.
So the patients we've been seeing in Alabama, Jason, typically have been more of the folks who have dropped out of care. They stopped taking their antiretrovirals, those who are HIV infected, and then they show up with a pretty aggressive form of Mpox. Are you noticing a difference in how patients present if their virus HIV is controlled versus if it's just more that they aren't on therapy and their viral loads are high?
Yes, I think we're definitely seeing a difference in persons who are immunocompromised, whether that's with a low CD4 count or with a high viral load, compared to persons living with HIV who are on antiretroviral therapy and have undetectable viral loads and good CD4 counts. Traditionally with Mpox, we see a prodrome symptoms like fevers, chills, headaches, muscle aches, swollen lymph nodes prior to the rash. What's been really interesting during this outbreak is that we've often seen the rash first, frequently in the genital and perirectal regions, which may be related to modes of transmission, and then the prodrome occurs after that.
Hmm.
For people who are immunocompromised, like you just asked about, we've seen really severe disease with severe necrotizing skin lesions that really struggle to heal, as well as disseminated viremia affecting multiple organ systems, most commonly the lungs and GI tract, but can affect almost any organ. It's been seen on a lot of pathology reports as well.
So people can die from this. It doesn't happen all that often. Is it usually the multi-organ failure that causes the death?
I think so. There's been about 60 deaths in the United States, so a mortality rate of about 0.2%. And the vast majority of them have been people who've been immunocompromised with severe viremia, with virus, again, on pathology reports found in multiple organs. They can pass away for that, or in some cases, they've just passed away from infection, having been in the hospital for a really long period of time with large open skin lesions, very similar to what we see when we work with patients who have burns.
Yeah, it's like a burn patient, right? So let's say this somebody shows up with maybe this newer clade, which is what we're seeing, and as you mentioned, there might have genital or perianal lesions. A lot of other things can look like mpox. What's your approach in terms of testing, and do you use empiric therapy while you're waiting for the test result?
Yeah, that's a great question. So there's really two questions in there. So I'll answer the first one first, and that's the question about sort of the differential diagnosis. Particularly in the outbreak that we've been seeing, it's really been closely aligned with sexual activity. And so keeping a differential diagnosis for other sexually transmitted infections that can look similar, things like syphilis, HSV, are really important. We should be doing regular STI screenings of gonorrhea and chlamydia as well. But we also need to think about other causes of ulcerative disease. Things like zoster and shingles can look very similar. In children and probably in some adults, enteroviral infection as well can also look similar. So making sure that you have a wide differential is important. At the same time, making sure that we keep Mpox in our differential for those other things is really important as well, because we are still seeing cases and making sure we can make the diagnosis.
Then how would you test?
So in terms of testing, the test is made from from PCR of a lesion. When collecting samples, we always recommend people collect two samples from two separate skin lesions just to reduce the risk of a false negative. And one thing that I always like to highlight is that really you just need to vigorously swab the top of the lesion. You don't need to unroof or aspirate the lesion. In fact, you should avoid that to reduce the risk of injuring yourself and exposing yourself to the disease. There's enough virus in these lesions that just vigorously rolling over the top is plenty to make the diagnosis.
And you mentioned healthcare workers. Typically, what we do if we suspect mpox is we gown up and have masks and a face shield with gloves. Is that sufficient?
So the current CDC recommendations for personal protective equipment for Mpox include gown, gloves, eye shield, and an N95 respirator. Again, they did a really nice recent review that demonstrated there really is not evidence of aerosol transmission or respiratory transmission, but because of the theoretical concern and some concerns in animal studies, they continue to recommend that healthcare workers wear the N95 to reduce any risk of transmission.
So now you've tested someone for mpox and you want to go ahead and start treatment. I assume where you are, you're going to refer to your study, the STOMP study. Tell us a little bit about that for people who have access to the study.
So, first and most importantly, is that I want to highlight that everyone does have access to the STOMP study. It's being done at almost 60 sites in the United States, but most importantly, it has a remote enrollment option, which allows us to enroll people no matter how far away you are from a study site. Everybody who tests positive for Mpox is potentially eligible for the STOMP study and should be referred to at least learn about the study.
And what does the study evaluate?
So, this study is to evaluate the effectiveness of a drug called Tecovirimat. Tecovirimat is a novel antiviral that targets a specific part of orthopox virus replication. So it's thought to be a pan-orthopox virus drug that was actually initially approved for smallpox. It was approved for smallpox through what's called the animal rule, which means that it was approved for efficacy through animal studies and then a small human safety study. And so we really don't have a lot of human efficacy data on this drug. And that's what the STOMP trial is trying to answer, whether or not this drug works to improve, shorten the duration of symptoms in persons with Mpox.
And this is also referred to, I guess, as TPOXX. Is that correct?
That's correct.
So
Yep.
whether or not we use TPOXX, we used a lot of it in 2022 before the study was there, just, I guess, on the blind faith that it would work. What's the preliminary evidence from the experience that a lot of clinicians had? Does it seem like it worked a lot of the times, or maybe not?
So I think it's really challenging when you have a naturally self-limited illness to know whether or not a drug works without a randomized control trial. I think, I had a unique experience in New York City where we had a lot of patients very early on calling for treatment, more than we could handle in New York City and more than places were able to provide Tecovirimat. So our clinic, I went in 10 sessions a week to provide care to patients. And every Friday I would get, as in all care settings at 4 p.m. on Friday, you'd get a bunch of phone calls and you'd feel terrible because these were people that you'd schedule for first thing Monday morning because you just didn't have the ability to do it over the weekend. And inevitably, every Sunday night when I would go to call patients to see how they were doing, half of them were so, we didn't collect this data systematically, I wish we did, but half of them would say, oh, I'm doing much better now, I don't need to come in.
Oh,
And I think that's a unique experience that really colored the way I looked at when we designed STOMP, in that some of these people got better and some of them didn't. And so the question really is, does this drug work? And I think there really is equipoise for that question. I'll also tell you that, recently presented at ID Week were the results of the POM-007 study. So POM-007 study was a very similarly designed study to evaluate Tecovirimat in the Democratic Republic of the Congo. That study top-line results are available, and it did not show a benefit from Tecovirimat. Now, that study involved individuals with clade 1 disease. It had a high proportion of children or pediatric participants enrolled, and so we certainly need more information. But I certainly think we don't know yet whether or not Tecovirimat works. And the only evidence we have from the DRC really suggests that it may not.
do you think it has to do with when the drug is started? If it's started earlier in the course of infection, um, soon after symptoms, or if it's used late? A lot of viral diseases are better treated early. What's your sense?
Yeah, I think there's a lot of open questions around Tecovirimat. One is certainly the timing of it, and we know antivirals are going to be more effective early than late. The other is dosing. Remember that this is really based on non-human primate studies. And when we tried to look at PK in people, both the group out of Italy and some of the preliminary STOMP data suggest that we're getting lower PK levels than we expected. And so it could be an issue with timing. It could be an issue with dosing, or it could be an issue that the drug is either not the right drug or alone is not the right drug, which you also seen in other viral illnesses as well.
So, what's the dose that you're using in your study?
So we're using 600 milligrams twice daily, which is the approved dose. It goes to 3 times a day for people who are over a certain weight.
Okay. And is that the same dose that they used in the study out of the Congo?
It is. That's the dose being used by all the current clinical trials, as that's the sort of dose that was studied in humans for safety and in animals for efficacy,
So
or the
again,
equivalent dose in animals.
I realize that sounds like I'm pushing your study, but I think it's really important to know. So, refer to the STOMP study. If someone doesn't have access, there's a way to get this from CDC or to have a waiver that allows you to treat. Can you tell us briefly about that?
Yeah, for people who are severely immunocompromised or have severe disease, you can still get this drug through the expanded access investigational drug mechanism. On the CDC website, there's both a link and a phone number, and you can reach out to them for a clinical consult if you have a patient who has either severe disease or is severely immunocompromised and not interested in participating in a clinical trial.
So early on in 2022, and we used to try to treat right after we tested because we thought it was better to just get the treatment on board. But there were several times when the test came back negative. One case in particular where it looked for all the world to be Mpox and it turned out to be syphilis. So it's always important. It's always important to check for, as you said earlier, the multiple STIs. But do you have a feeling about waiting for the test or just going ahead and doing empiric treatment? What does the study allow?
Yep. So the study absolutely allows you to enroll empirically. If you there's a few criteria. You had to be sexually active within the prior 21 days, clinician suspicion for Mpox, but you can enroll empirically, and we have been encouraging people to do that because, again, I agree with you. I think the earlier we enroll people, the earlier we get them on treatment, the better chance we have of seeing a difference if it works.
Well, I think that's really clear. Just to summarize what we've talked about so far, uh, Mpox really it was around as sort of a zoonotic infection sporadically happening, and then this large outbreak in 2022, and we stumbled into um, the Tecovirimat for treatment, and then uh, we started having questions about whether it really is efficacious. So the STOMP study was made available, and it's now in plus 60 plus sites across the country. So we should be able to find a site and get people into the study when we suspect uh, Mpox, and we should try to get the treatment started as soon as possible. I want to segue over to vaccination. And like you
Mhm.
said earlier, this is in the family of smallpox. And so it seems that the smallpox vaccination for those of us who were born prior to, I believe it's 1967, that would include me, had smallpox vaccinations routinely. And we don't seem to be as at higher risk as someone who was born later and already has a smallpox vaccination. Is the same vaccine being used for Mpox today? And did I get the date right? Was it 1967? That's what I recall.
I think so. I don't remember the
Okay, we can
date, but I
double.
can tell you that we are using a different vaccine today than we used back then. So back then we used the live vaccines, the ones that would leave the take on your arm, but also have the risk of sort of spreading to other people who may be immunocompromised.
Right.
During this outbreak, the preferred vaccine, and actually the only one used in the United States so far, has been the modified vaccinia anakinra one, also known as Jynneos, which is an attenuated vaccine, a live attenuated vaccine, um, that's non-replicating. So it's a live vaccine that's non-replicating, meaning it doesn't leave the take and it doesn't have the risk of spreading to other people.
And so, who are you recommending to receive that vaccine?
So, currently vaccine is recommended by the ACIP for individuals who are most vulnerable to an Mpox infection. So that includes people who are gay, bisexual, and other men who have sex with men, who are sexually active, um, or may intend to be sexually active, who are the most vulnerable group to Mpox.
And are we seeing this in cisgender women as well?
So we're seeing a few cases in cisgender women. Again, it's not as frequent in other populations as it has been in gay, bisexual, and other men who have sex with men. And so there is not currently a recommendation for cisgender women unless they're sex partners with gay, bisexual, and other men who have sex with men.
Okay, so
Sorry, I should actually clarify that. I apologize. It's actually gay, bisexual, and other men who have sex with men, transgender people, or non-binary people who are sexually active. So you had greater than one STI, more than one sex partner, sex at a commercial venue, or sex in an association with a large public event.
so it's great that we have a vaccine. My sense is that the uptake is not as strong as we would like it. Can you give us an update on how many people at risk who maybe should be taking the vaccine or have actually received it?
So I think it's very dependent on where you're located. I know that we're over 50% of those who would be eligible in New York City having received it, but I know that other jurisdictions have much lower vaccination rates. The other thing I'll say about vaccination along that line is that it's a two-dose vaccine, and many people got their first dose during the original outbreak when everybody they knew was getting Mpox, and then as the outbreak waned a little bit, people have been more hesitant about getting that second dose. But we know they're not fully protected without that second dose. So there's still a lot of work to be done, even when we were able to get first doses into people.
And a common question that comes up is, let's say we have somebody, as we say in the South, sure enough, had Mpox, and then they come back to us a couple months later and say, I'd like to get the vaccine. What do you tell them?
Yeah, so currently vaccination is not recommended for people who've previously had Mpox. The immune response to prior infection is actually quite strong, and we've seen incredibly few cases of reinfection across the country and actually across the world during this outbreak.
So in that regard, it's different than COVID, fortunately, and it does seem to
Very different than COVID.
have lasting immunity. And just based on the live vaccinia vaccine that I received, it seems like that immunity lasts potentially for decades. Is that what you guys are thinking now?
That is what they're thinking. They do still recommend people who got vaccinated in childhoods or years ago get revaccinated if they're the group that's vulnerable to Mpox now. But certainly it's clear that that Mpox confers protection that's much better than that for vaccination, or Mpox infection confers protection much better than that for vaccination.
Yeah, it makes sense. We're living we kind of are getting used to this notion of a new emerging outbreak happens and we have to, fly the plane and make decisions without a whole lot of information, just extrapolating from prior experience. And you guys seem to be doing a lot of that with Mpox at the present time.
Absolutely.
Yeah. So our time has rapidly gone by. It's so great to have you on. Are there any parting comments? What do you think the future is going to have with this? Do you have any sense?
I think there's two things to think about the future. The first is that in the United States, Mpox decreased but never went away. In 2022, we were seeing almost 650 cases in a day at the peak. And now across the United States, we see about 7 cases per day or 200 per month. So it's important to remember, and that's been pretty stable for about a year. So it's really important to remember that Mpox is probably here to stay, at least for now. We need to make sure we're offering vaccination to our patients and keeping in our differential diagnosis so we can make the diagnosis and prevent further spread. And also keep in mind that globally, this situation is much more complicated. There's a second public health emergency of international concern declared just in August for Mpox because of the clade 1 outbreak. While cases in the United States and in Europe have decreased dramatically, they're actually increasing in the Democratic Republic and surrounding countries. And so making sure that we do everything we can to help those countries, providing vaccination and other things, is important, because really managing Mpox and getting it under control really requires a global strategy.
Couldn't agree more. And I want to reiterate what you said earlier, that is that when you suspect there's a case of Mpox, make sure you're checking for other STIs. And sometimes they travel together like all STIs do. Jason, you've been wonderful. Thank you so much for joining us. I think we covered a lot of ground in just a short amount of time. So thank you for your time, and we'll probably circle back to you at some point in the future to get an update.
Thank you so much for having me.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.